So just like with the respiratory disorders, a lot of cardiac disorders have similar symptoms, shortness of breath, fatigue, maybe cyanosis, swelling, lots of different things. So it's hard sometimes, especially when you're just learning about them, to distinguish between all the different things. So we're going to sort of talk about four main categories: vascular, valvular, electrical, electrophysiological, or heart failure. And they don't all, and then we're going to talk about congenital and genetic disorders as well, but they don't, they're not all separate. They can lead to, one can lead to another. So arrhythmias can lead to heart failure. Arrhythmias can lead to myocardial infarction. Coronary artery disease can lead to heart failure. All the different vascular, valvular, whatever disease, eventually almost everything ends up in heart failure, or could potentially. Just for fun, heart failure could exist on its own. So let's just start talking about heart failure and then we'll go through all the other ones. It'll be fun. So we want to understand the pathophysiology of heart failure. What are the changes in the cells? What are the changes that are happening that cause this? Differentiate between different types of heart failure. And we'll talk about two different ways to classify heart failure and recognize the clinical implications for PT practice, including red flags and safety considerations. We'll talk a little bit about the medications for heart failure, but then there is a little separate lecture that talks about cardiac medications. And there's a great little exercise in the book where it lists a bunch of names of medications and you have to say what it is. Is it a beta blocker? Is it a diuretic? And I'll give you some tips for how to tell them apart. So, heart failure is when your heart is unable to keep up with the demands from the body. So it can't pump enough to get the blood all the way through the body. Lots of different risk factors, including hypertension, advanced age, obesity, smoking, physical inactivity, diabetes, metabolic syndrome. Remember those? Those risk factors. So a lot of the risk factors are modifiable through lifestyle changes. This is where we can make a significant impact. A lot of times people are coming into PT, maybe their cardiac issue is not their primary issue. And we can make an impact by educating our patients on how they can better manage their cardiac symptoms. So, heart failure can be classified in different ways. It can be classified by function. So, systolic failure, which is a problem with the pumping mechanism, or diastolic, which is a problem with the filling mechanism. If you recall, systole is when the heart is contracting. That's the high number on the blood pressure. So, problem with pumping. Diastole is when the heart is filling and relaxing. So it could also be classified by location. We talk about left-sided failure or right-sided failure. So left-sided failure is sort of problems between the on the left ventricle and that backs up into the lungs, and right-sided problems between the right side of the heart and the lungs, and it backs up into the systemic circulation. So classifying it these different ways helps us understand symptoms and treatment approaches, but left-sided failure can progress to right-sided failure. Right-sided failure can progress to left-sided failure. So they're all related. We'll talk about them. So systolic failure is a problem with the pumping mechanism. The heart can't pump efficiently. So either the cardiac muscle is damaged or weak, maybe because of ischemic heart disease where the oxygen to the heart muscle is diminished. I always say the heart is its first best customer. The first exit off the aorta, exit 1A off the aorta, goes to the coronary circulation. So the heart feeds itself first. It takes care of itself first. And then the second exit 1B, is the carotid artery going up to the brain. So if the heart and brain aren't working well, there's no point in oxygenating the rest of the body. So if the heart can't pump efficiently, the ventricles expand, the walls become thinner, and overstretched muscles contract with less force. So these are our weakened, overstretched muscles. We've seen those in skeletal muscle and different things. So if the heart's unable to generate enough force to pump out an adequate amount of blood, extra blood in the heart causes the heart to expand, and it can also cause backup problems eventually. So diastolic failure occurs when the heart can't fill adequately. So it's not receiving adequate volume to fill the heart to expand it enough to elicit a strong contraction, or the walls are thickened, you have hypertrophy, and so it's not elastic enough to fill enough. So you just can't get enough volume for a strong contraction, and long-standing hypertension is often a cause of diastolic failure because the heart has to work against that peripheral resistance. So cardiac output is stroke volume times heart rate. So if you decrease your stroke volume, your body's probably going to compensate by increasing your heart rate. And we'll talk about why that could be a problem in a little bit. So left-sided heart failure is commonly caused by problems with the mitral valve, either stenosis or prolapse. So the left ventricle dysfunction or hypertension because the left ventricle is having to work against that increased peripheral resistance in the arteries. So the key symptoms that we're going to recognize, dyspnea, shortness of breath, that's everything, right? A lot of cardiac and respiratory things have dyspnea. Persistent cough, that could be respiratory or cardio. Orthopnea, difficulty breathing when lying flat, like, oh, that's cardiac because the left side is backing up fluid into the lungs. And so when you lie flat, that extra fluid in the lungs makes it difficult to breathe. A lot of times coming back up, a lot of people tell me that they sleep in the recliner. And I ask them why. They say, oh, I have trouble breathing when I'm lying flat, or it hurts my back, or some other reason. If somebody tells you a significant, important thing like that, you should ask them why. And when people say like, "Oh, I can only walk for 10 minutes before I have to sit down and rest," I ask them why. Is it because your back hurts? Is it because your legs hurt? Is it because you're short of breath? Is it because you feel like your heart is beating too hard? What are the key symptoms? Fatigue and dizziness and syncope or fainting, those are also symptoms of other types of heart failure. Tachycardia and palpitations and reduced urine output. So those can be um, symptomatic of left-sided or right-sided heart failure, some of them. Orthopnea sort of and dyspnea are sort of the key symptoms to distinguish it as left-sided heart failure because blood and fluid back up into the lungs because the left ventricle can't handle the workload. So we talk about forward symptoms and back up symptoms. The forward symptoms are the dyspnea and the tachycardia and the palpitations and the fatigue and dizziness. The backup symptoms are the persistent cough and the orthopnea and the reduced urine output as well. So think about left and right-sided heart failure based on forward versus backward symptoms. So with right-sided heart failure, it can be caused by left-sided heart failure, just to make it interesting. It can be caused by pulmonary valve stenosis. So stenosis is narrowing, and if the pulmonary valve narrows, then it's harder for the right ventricle to push the blood into the lungs. Pulmonary hypertension, again, it's harder for the right ventricle to push the blood into the lungs. Septal defects, so the septum is the division between the right and left side of the heart. That messes up how your pressures and rhythm is going in your heart. Left-sided heart failure can progress to right-sided heart failure, just to make it interesting. The key backup symptoms are the blood backs up into the venous circulation because the right side of the heart can't pump effectively into the lungs. So dependent edema, legs when you're standing or sitting with your legs down, or sacral edema when you're lying down. Pitting edema, where the indentation remains for seconds to minutes after putting pressure on it. Jugular vein distension, and that's fluid backup again. Ascites, abdominal sweating, if you have long-standing right-sided heart failure. Nocturia, which is frequent nighttime urination, and potential kidney and liver problems. So right-sided heart failure backs up into the systemic circulation, but it has a lot of the same forward symptoms as left-sided. Left-sided heart failure backs up into the pulmonary circulation, similar forward symptoms. So the body, if we're not getting the right amount of oxygen, the body's like, well, wait, we got to do something here. Let's Try speeding up the heart rate. That sounds good, right? Well, you increase the heart rate, and now you're putting extra work on a heart that's already weak. That's a problem. Um, the body will increase the blood volume by causing you to retain more fluid. So now there's more blood volume, more blood pressure, more peripheral resistance, and that also makes the heart, affects the heart. So these compensations that the body does eventually worsen your heart failure. But that's what our body does. So it puts increased filling pressure to stretch the heart more. If the muscles are already stretched out and weak, that's not going to work. Increased muscle mass, cardiac hypertrophy. Now you have less room in there to put blood, and that's going to decrease your output again because it's going to decrease your stroke volume. So eventually, the heart failure worsens because you have increased oxygen demand, increased workload on a failing heart. Overstretching leads to weaker contractions, and thicker walls reduce the filling capacity. So the Frank Starling mechanism is, I think it's named after the two people that elucidated it. Initial stretch improves contraction, but excessive stretch weakens it. So in a healthy heart, if you have increased venous return, that's going to cause increased cardiac output. If you have a weakened heart, because the muscle's being stretched excessively, it's not going to help. So common medications, diuretics, which get rid of fluid, ACE inhibitors, which um, lower blood pressure, and beta blockers, which also lower blood pressure and lower heart rate. They These are some of the common ones. We'll talk about it in another lecture, specific things. One of the ways to tell the medications apart is their ending. So diuretics tend to end in "ide," ACE inhibitors end in "pril," and beta blockers end in "lol." So, or all, OL. So if you see, there's in the book, there's a little exercise for matching up the type of medication with the name of it, and that's how you could do it. Even if you've never heard of that medication before, do it by the suffix, and you'll get most of them. So side effects for diuretics and an ACE inhibitor can be dizziness or orthostatic hypotension. So that can be an issue during PT. For beta blockers, it artificially lowers your heart rate. So you have reduced exercise tolerance and more fatigue. And you can't use the heart rate as a reliable measure for exertion. You have to use rate of perceived exertion because beta blockers blunt that heart rate response to exercise. So we got to teach our patients how to use rate of perceived exertion to tell how hard they're working. Physical therapy, we're going to do aerobic exercise training, low to moderate intensity, and I'll talk about the exercise guidelines in a minute. Resistance training, lightweight, high rep, avoid the Valsalva maneuver because that increases intrathoracic pressure. We're going to instruct in breathing exercises, diaphragmatic breathing, pursed lip breathing, activity pacing, and energy conservation. Balance training for fall prevention because those medications that make you dizzy can lead to more falls, and patient education on activity modification and symptom monitoring. So for exercise, we're going to start with 3 to 5 minutes. It's not very long, but the rest of our session is going to be all that other stuff. We're going to progress gradually. So there have been a lot of studies in the last couple of years that have showed that interval training is really helpful for people with cardiac disorders and respiratory disorders. And the intervals are not going to be like the same intervals you would do with a healthy person. You might start with like a 30 seconds of work and 2 minutes of rest, and then 30 seconds of work and 2 minutes of rest. And during that 2 minutes, what do you think you're doing? Patient education. You're not just sitting there. And you're monitoring vitals. Good thing to do. We're going to teach the patient how to use the rate of perceived exertion scale. We want to shoot for being somewhat hard. They might not be able to do that right away. They might have to build up to that. You want to allow for a longer warm up and cool down and monitor their symptoms continuously throughout exercise. When are we going to stop or modify treatment? Severe shortness of breath at rest or with minimal activity, that is, don't start exercising. Chest pain or pressure, excessive fatigue or weakness, dizziness or near syncope, like they almost feel like they're going to faint, Um, if they report rapid weight gain, more than 2 to 3 pounds in 24 hours, that is a red flag. New or worsening edema, and the rapid weight gain is usually a sign of new or worsening edema. Palpitations or a regular heartbeat or a persistent cough with frothy sputum, it means your lungs are full of fluid. So when in doubt, stop the activity, consult with a supervising PT or physician or other healthcare team member, and document all your observations clearly. So ejection fraction is a measure, and it's usually used to classify heart failure. So if your heart failure is considered to be less than 40% ejection fraction, normal is between 55 to 70%. The if you're below 40%, then you're considered to be in heart failure. If you're below 25%, you're considered to be in end stage heart failure. However, it can be reversed sometimes. So, depending on what the cause is. So, ejection fraction means if you have a milliliter of blood in your left ventricle, I'm just making that up. Let's say 10 milliliters of blood, your left ventricle. In one pump, what percentage of that gets shot out into the aorta to go to the systemic circulation? So if 5.5 to 7 milliliters get shot out, that's 55 to 70% ejection fraction. So it's not nobody has 100% ejection fraction. There's always a little bit of blood left in your heart. Um, but the more efficient your heart is, the better your ejection fraction. So with systolic heart failure, it's usually an ejection fraction of less than 40%. The heart can't pump effectively because the muscle's weak, and so there's less blood ejected with each beat. With diastolic heart failure, it might be a little bit low, but ejection fraction is often preserved. The heart can still pump pretty well, but it can't fill adequately because the walls are stiff. So knowing the ejection fraction helps predict exercise tolerance and guides treatment intensity. You see people in the hospital with really low ejection fractions. It's shockingly low. And you have to know if somebody has like a 5% ejection fraction, they're not going to be doing any hard exercise, I'll tell you that. And walking is going to be a hard exercise for them. So that's going to be documented in the medical record, and knowing the ejection fraction helps predict exercise tolerance. So low sodium diet is recommended for heart failure because sodium retains water and increases blood volume. Increased preload because of increased blood volume means more work for your failing heart. It worsens edema and increases your symptoms and raises your blood pressure, and that increases the afterload. So both the preload and the afterload are increased. So daily weight monitoring is something that people should do. However, that might seem easy for us, for mobile people, but for people with heart failure and people who have poor mobility, stepping onto a scale can be a really challenging activity. So if they live alone, that might be something that you do in PT sessions is monitor their weight. If they live with somebody, teach their caregiver how to safely weigh them every day. And emphasize we're not talking about fat here, we're talking about fluid. So it's important for them to monitor this because you can tell if your heart failure is worsening if you have a greater than 2 to 3 pound weight gain in a day or 5 pounds in a week. And it's not fat, it's fluid. So if the doctor orders fluid restriction, you should do it. Regular moderate exercise helps with fluid balance, smoking cessation, of course, and stress management. So patients may have a significant number of barriers to lifestyle modification. And so our job is not to criticize them for not doing things. It's to help them and help remove barriers to make it easier for them. In PT, we can explain activity modifications, we can teach energy conservation, we can demonstrate proper exercise technique, and then have our patient demonstrate it back to us. And we can reinforce the recommendations that were made by their physician, like fluid restrictions and medication consistency, that kind of thing. Key takeaways, heart failure is manageable, and PT can play a crucial role in improving the patient's quality of life. Some of my inpatient, my friends that work in inpatient have said there's been a lot of increase in heart failure exacerbations over the last few years being admitted to the hospital, and I don't know why that is. But so it's something that you need to know. Um, Knowing the types, systolic versus diastolic or left versus right side, monitoring using the rate of perceived exertion scale with beta blockers, start slowly, progress exercise gradually and safely. Red flags, you got to really pay attention because patient safety is number one. Educating patients on their lifestyle modifications that can help them manage their heart failure. So, heart failure patients can really benefit from appropriate physical therapy interventions, but they need way more careful monitoring than people that don't have heart failure. And so, careful monitoring and safety are essential for successful outcomes. We're going to prioritize patient safety, communicate with PT about any concerns or changes in patient status.